Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, good evening for all the audience, wherever you've been. Our talk today is going to be about insulin pumps for General Pediatric Residents. Basically, all what you need to know for your on-call shift. I have nothing to disclose in relation to this presentation. The outline of the talk will be a little bit of introduction about the insulin pumps, the main problems and troubleshooting, switching to subcutaneous insulin, and taking actions. Insulin pump, as you see here, most of the insulin pumps, the ones are available in our region, they are tubed kind of pumps. In other parts of the world, there are tubeless insulin pumps. So the one that it's been demonstrated here has got a cannula, goes underneath the skin in the subcutaneous fat, with adhesive in here to keep the cannula in situ, and we keep it for 3 days. And there is a tube going to the reservoir there, and this is the home page where you could control the pump. The tube is long enough to enable the child moving this pump around. Most of the people, they put it in their pockets, but they can fix it on their belt, or they could wear a band. People prefer to keep it in a protected area, or some others, they put it on their thigh, for example, with a band. As a general pediatric trainee or resident, you may get a call from the surgical ward to say, we've got a listed patient for theater tomorrow, and by the way, he is type 1 diabetic and he's on insulin pump. So can you put a plan in place? Or you may get a call from the emergency department saying, hey doctor, we got a patient, we suspected DKA, however, he or she is on continuous subcutaneous insulin infusion, which is insulin pump. Just before going into that, we just reminding you that the patients, majority of them are on MDI regimen. They're having multiple injections per day. But these days, since the pumps became more available, there is a shift of patients using the MDI regime to the insulin pump for many reasons. If you look at the times they inject themselves with insulin, minimum 4 times a day, 3 with a short or rapid-acting insulin, pre-meals, and 1 injection for the long-acting insulin. So if they snack in between the meals, so they have to inject themselves furthermore injections. So let's say the minimum is 4 injections a day. So over 3 days, there will be like 12 injections. Whereas if they were an insulin pump, it would be only once in 3 days to fix the cannula. So over a month, the multiple daily injections can reach up to 120 needles a month. Whereas for the insulin pump therapy, putting the infusion set and inserting the cannula may happen only 10 to 12 times a month. So using the pump, meaning 90% fewer injections. Not just that, but with insulin pump, you can control the basal rate, the amount of insulin that's being given continuously 24/7, that can be adjusted, can be set in a certain amount, which could help those patients who are experiencing the dawn phenomenon by having a rise in their glucose in the early hours of the morning. So you can perhaps give more basal rate during that time. You can adjust the basal rate as you see appropriate to fit with the lifestyle of the patient. So in this example, so for this patient is running on 0.9 units per hour from midnight to 8 in the morning, from 8 in the morning to 6 p.m. the infusion rate is less, 0.65 units per hour. And then from 6 p.m. to midnight, it's back on 0.9 units per hour. So you can create a time block, and you can change the infusing rate accordingly. In regards of having boluses with feeding, the normal bolus, it appears like that, but the beauty of these pumps, they could give more than just a bolus. The bolus can be set to be given over a period of time, and that's what is called square bolus. You can set the time between 30 minutes to 8 hours, or depends on the type of the food. Like if the patient is having lasagna, for example, you can do the dual bolus. So you give like 30% of the bolus up front, and the 70% you can choose the time between 30 minutes to 8 hours to be given. So this advantage of the pump and giving the boluses in different shapes and forms over different times could match and could help controlling the glucose according to the type of food that's being taken. Remember, patients on insulin pump, they are not using long-acting insulin. They are using actually a rapid-acting insulin. Therefore, a disconnection or an interruption in delivering insulin from the pump for any reason may result into hyperglycemia quicker than those patients on MDI regimen. And hyperglycemia can result into ketosis and even DKA. However, it's important to remember this, that the pump and tubing can be removed for up to 1 hour, leaving the cannula in situ. For example, if the child is going for swimming or bathing or contact sports such as boxing or rugby. Saying that, many of the pumps these days are waterproof, so patients could go swimming with it with no problem. Let me show you this video, since most of our patients in our center using this type of pump. So this video is from Medtronic. So this is the pump and the reservoir inside it, and it has been fixed on a belt in this patient. The tube carries the insulin through the cannula to the subcutaneous fat, and this gives it 24-hour basal insulin. So it will be given continuously based on the rate that's been set. When the patient checks the glucose, you can put the capillary glucose, can be measured through this glucometer, which is talking to the pump. So once you've got the reading in there, you can send the results, and then the pump will take that results on board. You put the amount of carbs, it will calculate the bolus to be given, and you just click on deliver, and that amount of insulin will be delivered accordingly. So the pump can tell how much to be given if you feed it correctly by giving the correct amount of carbs. There is a smart guard technology where the sensor here transmits the readings to the pump. And the beauty of this continuous glucose monitoring is you can set it at certain limits to avoid hypoglycemias. For example, these symptoms of shakiness, fatigue, blurred vision. So before experiencing that, we're using the technology here to put a set level, and if the glucose reaching that point, the insulin will be stopped from being delivered into through the pump until the glucose recovers, and then the insulin will be resumed. Then the data can be transferred using the CareLink software, so all the information can be downloaded and can be discussed with the patient accordingly. So I picked this video here because almost all of the patients that I'm looking after using this type of pump. Okay, Insulin pump problems and troubleshooting. The most common problems that could happen with the infusing insulin through the pump is either having bubbles in the infusion set or occlusions. About 40 to 60% of the pumpers would experience at some point having one of those kind of problems, which is easy to fix. Other problems could happen, like leaking pump reservoir. Sometimes the infusion sets coming loose, especially in our region when the hot weather leading to people get more sweaty. Therefore, it's very easy for the cannula to dislodge and coming out. Sometimes there'll be an injury to the small blood vessels resulting into bleeding, and the pumper always referring to that as a gusher when the blood is coming out. So basically, you just need to change the site of insertion. And rarely to happen if someone contracts an infection when there is no disinfection of the skin before putting the cannula there, or otherwise the blood reaching the cannula before it gets inserted. So there will be an infection outside of putting the cannula in. In that case, that area needs to be treated by local antibiotic, and sometimes patients will need even systemic oral antibiotics to facilitate the healing process, and decide to be avoid used in that situation. Mentioned the bubbles in the insulin pump. See in this example, it appears like a big bubble here in the tube. Here are other examples of having bubbles here and there. So when that happens, check with the patient whether did they prime air out of the reservoir when they've been refilling the reservoir or using a new cartridge. Did the patient prime all the air out of the tubing when changing to a new infusion set? Is there any loose connection at either side of the tubing? Have they used insulin straight away from fridge? Because sometimes if the insulin wasn't let to warm into room temperature, then later on that will result in having some bubbles. The occlusion could happen as demonstrated here, that because of the kinking of the cannula, or sometimes kinking of the tube, or pressure on the tube, and rarely having insulin crystals in the cannula itself that causing the blockage. Patients have to recognize any of those quickly to avoid the complications that may result from failure into delivering insulin. Some long-term kind of problems that happen with the insulin pump, especially if it's being used on particular side, then patient would experience lipohypertrophy, a swelling of the skin on those particular areas because of developing some lumps underneath that skin. I usually describe that to the patients as a place that's containing, as a sac containing insulin. That's why patients may not see the effect of infused insulin, and the hyperglycemia will be evident. Then sometimes will be a sudden gush of that insulin to the system, leading to hypoglycemia unexplained. So anyway, for lipohypertrophy, these sites have to be avoided completely until the skin healed. Some patients will experience lipoatrophy, where at the site of putting the cannula constantly, there will be atrophied skin, and the skin will be dipped in. So anyhow, any sort of lipodystrophy that resulted from the cannula site has to be avoided. And always we say, if you rotate the site of cannula insertion, then you would reduce the risk of developing any sort of lipodystrophy. But if the patient is using on the particular site more frequently, then they put themselves at higher risk. Interestingly, it has been found that putting a sensor on this hypertrophied areas is not going to affect the glucose reading. And that has been studied in a randomized trial, I believe. Now, let's take some clinical cases. The first case is a 7-year-old girl, non-type 1 diabetes mellitus, on CSII regime, continuous subcutaneous insulin infusion, presented to emergency room due to uncontrolled hyperglycemia. Mom gave a correction dose at home 2 hours ago. Capillary blood glucose at the moment is still elevated. It's 18 millimole per liter. The blood gas did not show acidosis as the pH was 7.32 and the bicarb is 19, basic test -3. So what is your action now? Let me give you a few options to select. Either to give a correction dose via pump, or to give a correction dose using insulin pen, or to check the ketone level first. Right, let's see the poll. You can vote one of those options. So 60% of you would like to know the ketone level first, while the other 40% being divided between either giving a correction dose via a pump or by using insulin pen. Right. For those 40% who chose to give a correction dose, how much would you give? Would you give 2 units, 2.5, 3, 3.5 units, 4, or 4.5? Right. So the answer to that, we need actually to know what is the ketone level at the time. This is important because if the ketones are below 0.6, so perhaps you just need to give a bolus using the insulin pump itself, and then you recheck the glucose in 2 hours. But if the ketones is a ketone level between 0.6 to 1.5, so there's a ketonemia, then you would need to give the bolus using insulin pen, and you need to increase the correction dose by 50% and rechecking the glucose in 2 hours. If it's a high ketone, when it's reaching more than 1.5 millimole per liter, in that case, certainly you need to give the bolus via insulin pen. In addition, you need to give double of the correction dose. So if there is no evidence of ketones, you just give a bolus using the pump itself. If there is ketones, depends on their level, you would decide on the amount of insulin to be given, either 50% extra on the correction or double the dose. And in all conditions, you need to give the insulin via pen. Here you would check the glucose in 2 hours, here you would check the glucose in 1 hour. And remember, if ketones are more than 0.6, then first dose of insulin must be given by a pen device, not by pen, to be given by pen, not by pump. And remember this particular area here, that's very important. The maximum 6-day dose should not exceed 20% of the total daily dose. And then you need to increase the basal rate by about 30% after changing the insulin cannula and infusion set. If you don't have facility to measure blood ketones, so back to the urine ketones. If the urine ketone is plus or 2 pluses, then that is equivalent to blood ketone of 0.6 to 1.5. If the ketones are 3 pluses, then that goes with the ketone in the blood more than 1.5. You need to discuss the case with the on-call consultant if the child is looking unwell, if the child is getting worse, if there is no response to 2 sick doses in the hospital. So going back to that, so you would give a correction dose here. In 2 hours, you may give another correction dose. In this scenario, you may give a correction dose. In 1 hour, you need to give another correction dose because you would check the glucose here in 1 hour. Okay, so if you gave 2 correction doses and there's no improvement, then you need to discuss. Right. To calculate the correction dose, we need the total daily dose of insulin. How are we going to get that from the pump? It's very simple and easy. If you're using Medtronic 640, you just go to the menu, history, then on summary, and then you find the total daily dose from there. If it's Animas pump, again, menu, history, and then you find it. The Omnipod, my records, will give you for last 3 days, and then you divide by 3 to find out the total daily dose per day. So in this particular case, let's say the total daily dose was 24 units, and the blood glucose now is 18 millimole per liter. So how many units of insulin are you going to give? Did you calculate that? Let's do it together. So first of all, we need to know the insulin sensitivity factor. And the rule here is to use the 100 rule. So to calculate the insulin sensitivity factor, let's get the pen. So the 100 rule is you divide 100 by the total daily dose. Okay, so in this example, the total daily dose was 24. So 100 divided by 24, it will give roughly 4 point something. So let's take it, round it up to 4. So that means each unit of insulin will lower the glucose by 4 millimole per liter. Okay, then we need to know how much to drop the glucose by. So the current reading is 18 millimole per liter. The glucose that we would like to run between 4 to 8 millimoles when you check it using the capillary blood. So basically, you need to drop the glucose from 18 to 8. So that is like you need to drop the glucose by 10 millimole per liter. You remember the ratio that we talked earlier about from here, that the ISF is 1 to 4. Now you need to drop the glucose by 10. So how many units of insulin to give? So in that case, you would multiply that by that, and then you divide it by this to find the x. In this case, it's going to be 10 multiplied by 1 divided by 4, and that is 2.5. So the correction dose here is 2.5 units. Okay, let's go from here to the case. We don't know so far what is the ketone. So ketone measurement is very important in that situation. So if the patient has no ketonemia, then in that case, the patient will receive only 2.5 units as a correction dose through the pump and recheck the glucose in 2 hours. If the ketones is between 0.6 to 1.5, then you need to give 50% extra. And that leads you to calculate it this way. You make 1.5 multiplied by that correction dose that we measured, we calculated, and it gives you the bolus to be given, which is 3.7 units. And if the ketone is more than 1.5, you give the double correction dose, which is 5 units. However, we said earlier, you need to know what is the 20% of the total daily dose. You should not exceed that 20% of the total daily dose. So 20% of the total daily dose, which was 24 in this example, will result into like a 4.8 unit. So in this example, instead of giving 5 units, you would give 4.8 units as a maximum dose. Now, we advise here to put to start a 30% basal increase after changing the infusion set. And using the temporarily basal feature, you can do that simply. So in Medtronic pump, you go on the temporally basal screen. which you can access it from the home screen, then basal, then temporal basal, and you set the duration of the time as well as the percentage. So in this example, if you want to give 30% extra, so we make here the percentage 130. So that's the 30% extra, and then you begin. You can set the temporally basal rate anytime between 30 minutes to 24 hours. It gives with 15 minutes increments. So it depends on the situation that you are in. So in summary, things you need to know before taking any action in advising about whether to keep the pump and give in a bolus or to use a pen instead of the pump. You need to know whether the patient is well or not. Is the patient in DKA or not? If the patient is actually in a DKA, you would disconnect the pump and you just follow the protocol that you have in your unit by giving intravenous insulin with infusion and stuff. You need to know what is the total daily dose, and we explained that, how to access that from the insulin pumps. Because if you ask the patient, sometimes it's difficult for them to know exactly how much are they receiving per day, because they would rely on the pump, and the pump will give basal rate as well as the boluses. So you need to know the total that's been given on average each day. You need to measure the glucose, and certainly it's very important to know the ketones, whether blood or urine, to decide which way you're going. You need to know some basics about the infusion set, as with the problems that we mentioned earlier, and how to deal with them. And insulin pen has to be available with the patient, as we say, to them, and advise them to use it in emergency if they are a pump user. Evans and colleagues, they mentioned that medication errors relating to insulin are common during hospital admission for someone with diabetes, and that could be associated with high incidence of severe hypoglycemia. So awareness is very important on these aspects. And due to the altered tissue perfusion in DKA, which can affect the insulin absorption, that would result in making the insulin pump perhaps unreliable. That's why patients with DKA, we prefer to manage them by the intravenous insulin infusion after temporarily disconnecting the pump. People on insulin pumps who are admitted to hospital should be encouraged to self-manage their pumps as much as possible, as long as they have capacity to do so. However, any patient who is unconscious and thus unable to self-manage the pump should have the pump removed and start on a variable rate intravenous insulin infusion. Now, let's move on to second case. 9-year-old boy on insulin pump presented to emergency room because he's running out of consumables. And now you, as a General Pediatric Resident, you've been called to advise on switching the insulin regimen into subcutaneous MDI, multiple daily injections. So what will you do? Give you options. Would you call the General Pediatric on-call specialist? Would you call the diabetologist or endocrinologist and consultant? Or would you ask the patient, what should I do? Or you know what to do? So please choose one of these answers. Okay. So I see like 80% of you choosing B, to call the endocrinologist consultant on what to do. Only 12% they know what to do. Okay. So it's important for us to remember that the basal rate that's been given by a pump, it has to be checked, because the basal rate is almost equivalent to the long-acting insulin that we were given before putting the patient on insulin pump. If you remember back, the patients on MDI regimen receiving two types of insulin, long-acting and short-acting insulin. The long-acting insulin is basically the basal insulin here in the pump. The short-acting insulin pre-meals is not going to be changed because the patient is carb counting and they would give the insulin based on the amount they're eating. So here we check the basal rate. It appears on the screen of the pump similar to this. So there is a time range from starting, ending, and what is the unit per hour. That's for 24 hours. So for example, in this patient is receiving 0.4 units per hour from midnight to 4 a.m. So that's like 4 hours on this rate. 0.85 units per hour from 4 to 8, that's another 4 hours on this rate. On this 9 hours, the patient is receiving 0.7 units. So you calculate how much insulin has been received in 24 hours, and basically that is your basal insulin. So the basal insulin, which has been calculated from this example, is 16 units. So you could give the patient either 16 units Glargine, for example, or you could give the patient 8 units of Levemir twice daily. Make sure when you give the long-acting insulin, you give it an hour or two before disconnecting the insulin pump, because the long-acting would need some time to start kicking off. So in that example, we know how much insulin to be given subcutaneously until the problem will be solved by getting the access to consumables. If the patient is going to eat, then that is not being changed, because the patient will be able to count the amount of carbs and then would know how many insulin to be given according to the insulin carbohydrate ratio. And that is still to be given by a pen until the consumables will be sorted out, and then the patient will be back to the pump. Third case. Now we're dealing with a 5-year-old boy on continuous subcutaneous insulin infusion, presented with persistent hypoglycemia while he was at his grandmother's house. Both parents are away, and on arrival, his glucose is 2.1 millimole per liter despite 2 rounds of giving him juice. We do advise our patients, if they have hypoglycemia, to receive 15 grams of carbohydrate. It seems to be this patient has been given 30 grams of carbohydrate and still hypoglycemic. What will you do? This time there's no choice. So you can either type out, so the answer is there now. So make sure this patient is, patient's pump is actually on suspend mode, because sometimes when the main guardian or the parents who are trained on insulin pumps are not there, so when the child is with someone else looking after them, they're not that much familiar, or they perhaps have forgot about these things. And despite the hypoglycemia is continuously there, the pump is still attached. So make sure there's no more delivery of insulin for that particular patient to prevent the persistent hypoglycemia. And it's very simple from the home page to reach the suspend mode, and then you suspend it, and then you recheck the glucose within 15-30 minutes and see what is the situation before you restarting the pump. Okay. Patients with hypoglycemia, they should receive further amount of carbs. If it's difficult to manage, you may need even putting patient on intravenous dextrose infusion to correct the hypoglycemia before you restart the pump. I hope that we covered the main areas that you need to know during your on-call shift. Here is an accessible manual of the MiniMed 640G. You can access from internet. It's about 300 plus pages, but it's very simple to navigate through. I have put this in because, as I said earlier, all of my patients are on Medtronic pump, and so I wanted you and my residents to be familiar with this, in case you got any kind of call about any one of my patients. Right, so I hope you enjoyed this session. I'll be grateful if you could spare a minute or two to give me your feedback. by either scanning this QR code, or if you can copy this SurveyMonkey link, put it on your browser, and then give me your feedback. It shouldn't take more than a couple of minutes, and your feedback is important for me for further development. Thank you very much, and best wishes.